Welcome to part 2 of anti-seizure drugs. Today we'll be discussing on some specific anti-seizure drugs such as phenytoin, carbamazepine, ethosuximide, Primidone. Phenytoin, carbamazepine, ethosuximide, Primidone. So let's discuss on them. They are specific anti-seizure drugs you should know, and they can come out in theory questions. Phenytoin. When you say phenytoin is an example of a hydratoin. What is added to that hydratoin actually makes it different from other hydratoin. So the chemistry. Phenytoin is a diphenylhydratoin, like a diphenyl group is added. So it's a diphenylhydratoin. It has a prodrug. The prodrug of phenytoin is called phosphenytoin. Phosphenytoin. Phosphenytoin is more water-soluble than phenytoin. And you remember, water-soluble drugs are not properly absorbed through the guts. So you majorly give phosphenytoin either intravenously or intramuscularly. So remember, phosphenytoin is the prodrug of phenytoin, and it's more water-soluble than phenytoin. Moving to pharmacokinetics of phenytoin. When we say pharmacokinetic, remember it means absorption, distribution, metabolism, and excretion. Now, the absorption of phenytoin depends on the formulation. If you should give phenytoin sodium, it is almost completely absorbed in the guts. It's well absorbed when phenytoin sodium is given. Next, the peak plasma concentration of phenytoin is 3 to 10 hours. It's within 3 to 10 hours. If you give somebody phenytoin, it takes 3 to 10 hours for the highest amount of phenytoin to be in that person's blood. That's what it means. Now, you do not give phenytoin intramuscularly. Why? Because giving phenytoin intramuscularly the phenytoin given intramuscularly can actually be precipitated in the muscles, and it will not be properly absorbed. You cannot predict the amount that will be absorbed, the amount that will enter into the work in the person's body when giving intramuscularly. It is phosphenytoin, which is more water-soluble than phenytoin, that is given intramuscularly or intravenously. But phenytoin itself is not recommended that you give phenytoin intramuscularly. All right. So we have through with the absorption. Let's talk about its distribution. Is it well distributed? Yes. Phenytoin is highly bounded to protein. And proteins are responsible for transporting drugs. This next point is very important. Phenytoin accumulates in the endoplasmic reticulum of some cells, such as the cells of the brain, the cells of the liver, the cells of muscles, and adipose tissue cells, the adipocytes. Take note, there is no kidney cells. They will bring it in exam and they will put kidney cells. It's not there. Good. Then we are through with its distribution. It's well distributed. We are through with its distribution. So it's well distributed. Absorption depends on formulation. Phenytoin sodium is well absorbed. Let's now talk about metabolism. How has it been broken down? It's been broken down by the liver. You know that liver is the primary site of biotransformation, of drug metabolism. Now, remember, for drug metabolism, you have two stages, stage 1 and stage 2. That's phase 1 and phase 2. Phase 1 includes things like oxidation, reduction, hydrolysis, hydrosylation. Those ones are phase 1 reactions. But majorly, they will just tell you oxidation, reduction, hydrolysis. There are many other phase 1. Hydrosylation is among phase 1. Phase 2 is conjugation reaction, where you're adding something to make the drug more water-soluble. Good. So, phenytoin is metabolized in the liver by hydrosylation. Do you get? By hydrosylation. Then it forms a metabolite, which we refer to as para-hydroxy 5-phenylhydratoin. We refer to it as HPPH for short. Para-hydroxy 5-phenylhydratoin. So when phenytoin undergo hydrosylation, that is what is formed, HPPH. Now this HPPH will now go into phase 2. And in phase 2, you remember it is conjugation reaction. You add something to make it more water soluble. And what you're adding here is glucuronic acid. Remember, glucuronic acid being added is what we refer to as glucuronidation. It is the most common phase 2 reaction. So glucuronidation occurs and it makes the phenytoin more water soluble and it's now excreted through renal route, that's through urine. The half-life of phenytoin is 12 to 36 hours. 12 to 30 MCQ question, 12 to 36 hours. So remember, it's pharmacokinetic. Absorption depends on formulation. Do you remember that? Good. Then distribution, well distributed. You can remember that. Metabolism, take note under a distribution. It is well distributed and it accumulates in some cells. You say there's no kidney cells there. Instead, you see things like liver cells, the cells of the brain, the cells of the muscles, the cells of fat, that's adipocyte, adipose tissue cells. These are the regions it accumulates. It does not accumulate in kidney cells. Then on metabolism, it's metabolized by hydrolysation in the liver. It forms HPPH after hydrolysation, and then that undergo conjugation and it's easily excreted to the renal route. Half-life 12 to 36 hours. So let's move to the mechanism of action. It has different mechanisms of action. It can inhibit sodium channel. Remember, we've already talked about the mechanism of action of anti-seizure drugs. It inhibits sodium channel. It can also alter the synaptic concentration of inhibitory neurotransmitter, increasing inhibitory neurotransmitter, and it can also stabilize membrane so that they will not be easily excitable. Next, what is the clinical uses? Clinical uses of phenytoin. It is used to treat simple partial seizure, complex partial seizure. Partial seizure is divided into three: simple partial, complex partial, and partial seizure that is secondarily generalized. It's not used to treat that. So it's used to treat simple partial seizure, complex partial seizure, and generalized tonic-clonic seizure. Do you get now? These are the three major seizures. Then additionally, it is also used to treat status epilepticus. So let's ask, what is status epilepticus? Status epilepticus is a form of seizure that occurs for more than 5 minutes continuously. Normally, when somebody has seizure for 30 seconds, 40 seconds, the person will be relieved, and maybe later on it will be another episode. But it just continues for 5 minutes. It can be very devastating and can lead to a destruction of some important structures in the brain. You call it status epilepticus. To treat status epilepticus, we can use what? Phenytoin. Remember that. Very important point. The adverse effect of phenytoin. The adverse effect in the CNS when taken in toxic amount can result in things like diplopia, double vision, ataxia, abnormal gait, you can't stand properly, vertigo, it's as if the world is turning around you, nystagmus, it's as if your eyeball are moving up and down. You also have other side effects like gingival hyperplasia, the gum becomes more enlarged, hirsutism, a woman having a male pattern of hair, coarse facial appearances. These are adverse effects. Vitamin D deficiency, which is referred to as no vitamin D, that's cholecalciferol, all right. Then megaloblastic anemia, vitamin K deficiency, hypersensitivity reaction. These are all different side effects, adverse effects that you can see from taking phenytoin. However, there's something we want to discuss about. For a woman who is pregnant, she should not be given phenytoin under any circumstance. Why? This is because phenytoin is teratogenic. Phenytoin can result in what we refer to as fetal hydratoin syndrome. It is teratogenic. It can cause different conditions in the newborn. It can cause cleft palate. It can cause cleft lip. It can cause congenital heart defect. Therefore, phenytoin is contraindicated in pregnancy. So a 32-year-old woman walk into your clinic and she's pregnant and is having an episode of seizure during pregnancy, maybe eclampsia. In eclampsia, you don't give phenytoin. Don't worry, in eclampsia, they will tell you the drugs of choice that is majorly used, not in this material, but in ONG. Anyways, so that's that, but I don't use these anti-seizure drugs there. Okay, so hematologically, talking about hematological aspect, what is the adverse effect? You should take note of the hematological adverse effect for each of the following drugs, because they have some little changes. For phenytoin, the hematological adverse effect include causing disorders like lymphadenopathy, inflammation of the lymph nodes, agranulocytosis. So taking of the two, phenytoin adverse hematological effect. The adverse hematological effect it will cause is lymphadenopathy and agranulocytosis. Now, let's move on to carbamazepine. Remember, I already mentioned that carbamazepine is an example of immunostimine. Good. Carbamazepine looks like phenytoin. It's similar to phenytoin, just that it has something that phenytoin does not have, which we refer to as a urido moiety. Urido moiety, that's that NCONH2 that you can see there. The urido moiety. Carbamazepine have it, but phenytoin does not. Let's go to the pharmacokinetics. Pharmacokinetics, it is almost completely absorbed in the gut, unlike phenytoin that it depends on its formulation. The peak plasma concentration for carbamazepine is 6 to 8 hours. The peak plasma concentration for phenytoin is about 3 to 10 hours. The half-life of carbamazepine is 36 hours. The half-life for phenytoin was 12 to 36 hours. So you can see the difference now. Next, remember, pharmacokinetics has to do with absorption. We said it is almost completely absorbed. Distribution, it is well distributed. It has a volume of distribution of 1 kilogram per liter. 70% is bound into protein. It's well distributed. Half-life of 36 hours. Let's talk about metabolism. Metabolism, it is metabolized in the liver. Excretion, it is excreted in urine. That's renal routes. Now, during the metabolism of carbamazepine, it can form a metabolite, which we refer to as carbamazepine 10-11 eposide. Carbamazepine 10-11 eposide is also an anti-seizure drug. It can also be used to treat seizure. So just take note, carbamazepine 10-11 eposide and a metabolite of carbamazepine also have anti-seizure activity. Do you get now? Phenytoin is a prodrug, take note, and it also have what now? Anti-seizure activity. But carbamazepine 10-11 eposide is a metabolite. It is carbamazepine that gives rise to carbamazepine 10-11 eposide, but it is phenytoin that gives rise to phenytoin. So you should be getting those points. How does it act? Mechanism of action of carbamazepine. It inhibits sodium channel. It inhibits it. It potentiates the effect of GABA. It's increased inhibitory neurotransmitter. So when they just ask you to discuss a mechanism of action, it will be very easy. You're already watching that in my previous video. Do you get? Clinical uses. It is used to treat simple partial seizure, complex partial seizure, and generalized tonic-clonic seizure, just like phenytoin. It looks like phenytoin, but it cannot be used to treat status epilepticus. You see, it's not here. It is phenytoin that is used to treat status epilepticus. Okay, adverse effect. It has adverse effect. It can cause coma. It can cause respiratory depression. It can actually cause drowsiness. It can cause blurriness of vision. In the GIT, it can cause nausea and vomiting. It can cause water intoxication, hyponatremia, hematological. Take note. Remember, for phenytoin, the hematological aspect, the hematological adverse effect is that it can cause lymphadenopathy and agranulocytosis. The hematological adverse effect for carbamazepine is that it can cause aplastic anemia and agranulocytosis. Aplastic anemia and agranulocytosis. So you can see aplastic anemia is here. That was lymphadenopathy, but both of them can cause agranulocytosis. All right, next we move on to ethosuximide. Ethosuximide, the chemistry. Remember, it's an example of a succinimide. So, ethosuximide is a 2-methyl succinimide. In the exam, they will put 2-ethyl, which is wrong. It's a 2-ethyl. Ethyl come before methyl. It's a 2-ethyl, 2-methyl succinimide. Pharmacokinetics. Absorption, it is completely absorbed orally. Absorption is complete. That's nice. Peak plasma concentration is 3 to 7 hours. 3 to 7 hours. Now, it is widely distributed, but it does not penetrate fat cells. You can see exam point now. Ethosuximide does not penetrate fat cells. Phenytoin accumulates in adipose tissues. It accumulates in fat cells, in liver cells, in muscle cells, in brain cells. Exam questions. Ethosuximide does not penetrate fat cells. All right. Volume of distribution 0.7 kilogram per liter. Volume of distribution of carbamazepine is what? 1 kilogram per liter. Is not protein banded, whereas carbamazepine is protein banded. Half-life is 40 hours. Half-life of phenytoin, remember, 12 to 36 hours. Half-life of carbamazepine, 36. Half-life for ethosuximide, 40. It is metabolized in the liver. It is excreted in urine, renal routes. You can see the way it is. It's talk about pharmacokinetics. We cannot leave that space empty. All right. Next, mechanism of action. How does it work? You must know this. Remember, I already explained in our first video. There's what we refer to as a slow T-type calcium channel, also known as a low threshold T-type calcium channel. That calcium channel is where calcium passes through to enter into the thalamus and then cause absence seizure. Blocking of this channel is how they normally act. So these drugs actually act by blocking that low threshold T-type calcium channel in the thalamus. Do you get? And therefore they can be used to treat absence seizure. So clinical uses, they are the drug of choice for absence seizure. Do you get? Other drugs that we can use to treat absence seizure include things like Phenytoin, you just say succinamide, then valproate. Valproate is aliphatic carboxylic acid, dimethyldione and trimethyldione, which is an example of oxazolidine-dione. Next, adverse effect. The adverse effect, we have GIT, we have nausea and vomiting. CNS, we have fatigue, headache. Then hematological, it can cause eosinophilia, leukopenia, thrombocytopenia, bone marrow depression. It's a very bad side effect. Bone marrow depression. It can cause hypersensitivity reaction like Stevens-Johnson syndrome, exfoliative dermatitis. These are some of the side effects. Let's go to the last drug, Primidone. Primidone is a barbiturate. Barbiturate, remember, we have things like phenobarbital, also known as phenobarbital, methylbarbital. Then we also have Primidone. Primidone is a barbiturate. All right. Primidone is a 5-ethyl. Just these names, just because they can just change it. That's what they do. 5-ethyl, 5-phenyl, 3-diazinine, 4,6-dione compound. That's what it is. That's what Primidone is. Now, Primidone is completely absorbed. It is banded to protein 25%. It actually have a half-life of 5 to 8 hours. It is metabolized in the liver by the help of cytochrome P450 enzymes. It is excreted via the kidney, renal routes in form of urine. It comes out as urine. Mechanism of action is that it stabilizes sodium chloride channel. Inhibit that sodium from actually inhibition of sodium. That's actually how sodium channel. That's how it actually works. It can also give rise to phenobarbital. Remember, it's among the barbiturates. It has a metabolite. Metabolite is phenobarbital. Once it gives rise to phenobarbital, it can actually increase GABA activity. It has GABA mimetic and GABA facilitate reaction. If you watch our first video, this will become very easy. Its clinical uses, it's used to treat essential tremor. Essential tremor looks somebody that does not have clinical knowledge. You think essential tremor is a Parkinson's disease. No, essential tremor, you see the hand shaking, but it's not Parkinson's. It's the second line drug in the treating of essential tremor. The first line drug in treating essential tremor is propranolol, beta blockers. All right, then this is the second line drugs. It's also used in the treatment of partial seizures and generalized tonic-clonic seizure. Adverse effects can cause depression. It can cause sedation, GIT, nausea, vomiting, abdominal pain. It can cause osteomalacia, that's vitamin D deficiency, vitamin B12 deficiency. It can cause folic deficiencies, resulting in megaloblastic anemia. Hematological, you see something like leukopenia. It has the same hematological symptoms you see in the last drug we just mentioned, ethosuximide. Thrombocytopenia. All right, then it's connected to lupus. Lupus. Let's quickly go to the summary. Summary. Take note. These are the mechanisms of action of anti-seizure drugs: increase inhibitory neurotransmitter activities, decrease excitatory neurotransmitter activities, block sodium channel, and inhibit slow calcium ion channel. If you watch this video, you get all of these points. We explain them. Now, note these points: carbamazepine, phenytoin, Barbiturate, all of them are used to treat partial seizure and generalized tonic-clonic seizure. Ethosuximide is a drug of choice for absent seizure, though you can also use valproate, trimetadione. Diazepam is the drug of choice for infantile spasm and febrile seizure. Febrile seizure is a form of seizure that can cause that results in children within 6 months to 5 years. Drug of choice for status epilepticus, we have diazepam is there, but we can also use phenytoin. Remember, phenytoin can also be used. Is that not true? All right. So thank you very much for watching this video. We appreciate